Okay, I have hit record. So thank you, Dr. McGeorge, for joining us today. We are here today to talk about what's going to be moving forward with COVID vaccines. So we'll open up the time for you first, and then we'll open up to media questions. Thank you again for your time.
Okay, thank you, Michelle. So thanks everyone for joining us today. I wanted to spend a little bit of time just talking about where we are today, as well as answer questions, and also want to specifically address the third dose of the vaccine. I know we're all hearing a lot of information from the CDC, from the FDA, from the White House, and it's really challenging navigating all this different information. We also are thinking we're going to get more announcements. We're expecting continued announcements and more information, and we continue to closely really follow this situation. We know there will be questions, and we want to be here for you to help navigate this. I don't want to scare people. That is not the intent, but I do think that we have a responsibility to help people, to share what is going on in the health system and in our state. Help them really understand what they're seeing, what we are seeing every day at St. Luke's Health System. So happy to talk about that too as we go on this morning. Let me just give you some details on that third dose for immunocompromised patients. That was announced about a week ago. St. Luke's has not yet started administering those third doses. We will in a few days, and we will let you know when we are ready to do that. We are dependent on a software build from our vendor to make sure that we have it right so that we can do that safely and make sure we're giving that vaccine, the same vaccine to that person, and et cetera. So waiting on that, it should be just a couple of more days and then we'll be ready to go. The reason why for this third vaccine in the series is because studies have shown that some immunocompromised people do not mount as robust an immune response to the vaccines as people who have normal immune systems. The biggest example would be people who have had solid organ transplants, so like a kidney or a liver transplant. After 2 doses of the messenger RNA, they may typically have about a 50% response rate compared with more like a 90% response rate for other people. So we do know that this third dose actually will get them back closer to the response rate we would see from someone who's not immunocompromised. And so that is really important that we are able to get those doses in. This messenger RNA, or this third dose, only applies to the 2 messenger RNA vaccines. So that would be the Pfizer and the Moderna vaccines. People do not need a physician's order to get that vaccine, although we, again, recommend you talk to your physician or provider about that, because sometimes there are decisions to be made on the best timing for that third dose of the vaccine. And we do know that the timing, at a minimum, you do need to wait at least 4 weeks from having had your second dose in that series. So that's kind of the third dose for immunocompromised in a nutshell. And I'll go ahead and take some questions.
Thank you, Dr. McGeorge. This is Joy. I think I'm back live now after rebooting Teams. So if anyone has a question, please raise your virtual hand and I will call on you if you could state your name, your organization, and your question. Hayat, I see you raised your hand first, so please unmute and go ahead.
Hi, Hayat Norimine from the Idaho Statesman. I just had a question. I know there's already a response from critics of the vaccine saying that people are no longer vaccinated. How are you responding to that? What's the message that you want to send to people who have had 2 doses of the vaccine now that there's the recommendation for the third dose?
Yeah, well, first of all, so keep in mind a couple of things. The recommendation that is now approved by the FDA is for immunocompromised people. And we know, and there is data And it's not surprising that people whose immune systems are not as robust are going to have a harder time responding to a vaccine. So we know that that's not surprising, and now is the time to get that vaccine. As far as the additional information that came out on people who got those vaccines months and months ago, like me, who I got my first Pfizer in December, I got my second Pfizer in January, healthcare workers and long-term care facility residents, at the 8-month point, we are expecting shortly that we also will be providing booster vaccines. So I do want to tell you that a couple of things is we have incredibly strong data that the vaccines are very effective against getting COVID. They are extremely protective, 90% protective against being severely ill enough that you need to be hospitalized or intensive care or dying from it. So again, for me personally and for my family, that is what I care about the most, is not being in that situation or having a loved one in that situation. So they today, even with 2 doses, are highly effective against that. What, however, we are starting to see is with the Delta variant, we are starting to see that people who have had the vaccines can in fact get a mild case of COVID. And what's really concerning about this are a couple of things. Is one is, again, that person could have symptoms of a mild cold and not even realize it or think about it, and so should get tested to make sure they don't have COVID, because if they do, they can very quickly spread it to others. Also, what happens, of course, is people can not have symptoms at all and can spread it. And so that's why, and I think that's why the CDC went back to masking regardless of your vaccination status. Because again, my masking, again, as I had the Pfizer vaccine, it is unlikely if I get COVID, very unlikely that I will become severely ill from it, but absolutely could I get it and pass that virus on to someone around me who is either unvaccinated or has not been able to respond to the vaccine. So again, imagine, if I have young children who are too young to get vaccinated, or if if my husband were a, kidney transplant patient and had not responded to the vaccine as well as other people would have, I'm putting those other people at risk if I get COVID. So vaccines, highly effective. I will tell you the most effective vaccine is a vaccine that is in the arm of somebody. And really, by far, what we're struggling with the most is just the overall low vaccination rate at all in our state. If everyone even had the 2 vaccines and didn't even get the 3rd booster, we would be in a far better position than getting boosters for some people. I mean, we just have to get more people vaccinated.
Thank you. And just a quick follow-up question. For immunocompromised, you mentioned organ transplants. Are there certain other conditions that show that you're more likely to need the 3rd dose?
Yeah, a couple of other examples are HIV, also patients on immunocompromising medications, or chemotherapy, actively undergoing chemotherapy for cancer. Those are some pretty common examples. One other thing, actually, I do want to add as far as the vaccination too that's happened. And I don't know that we've talked about this publicly in the media at St. Luke's, but I do want to remind people in the last couple of weeks, we've had some very significant, strong recommendations for the vaccine for pregnant people. And that recommendation is whether you're intending to get pregnant or whether you are pregnant. That recommendation has come out from ACOG, which is the National Organization for Obstetrics and Gynecology. It has also come out from the National Organization for Maternal Fetal Medicine, which are the doctors that specialize in high-risk pregnancies. And most recently, it came out from the CDC. The reason why that recommendation now is there, and it is strong recommendation, is because the data clearly shows that women who acquire COVID while pregnant are at increased risk of severe disease and even death. And also that, of course, then puts the fetus at risk too. So really clear change in the direction on pregnancy.
Thank you, Dr. McGeorge, for that important information and update. Katja, can you please state your organization and your question?
Yeah, hi, this is Katya from KTVB Channel 7. Switching gears a little bit, can you kind of illustrate to people out there as to what you're seeing in the intensive care units? We're hearing that most of them are at capacity and that there's very, very limited availability right now.
Yep, yes, that is true. We get calls from all over the country. We have, and I've also been in touch with physicians in other parts of the state through a role that I have. And the hospitals are getting calls from like Alabama, Arkansas, Louisiana to help and to send patients from as far away as there. So I think we also, of course, the majority of our patients are from Idaho. And the overwhelming majority of our patients in critical care are COVID patients. And of those, again, overwhelming majority are unvaccinated. And I think, again, what's really, really, really hard on our staff is they're tired. We actually were hoping that we were, on the home stretch here earlier this summer. And it is really, really hard. People are leaning in as that's what they do, and they're taking those extra shifts. We are opening up an additional intensive care unit, doing everything that we can. But yes, our beds are full. It's obviously a very dynamic situation. If you have a patient who improves enough to go out of the intensive care unit to the floor, or if we actually have someone die in the intensive care unit, which unfortunately happens, then that does open up a bed. And so the situation is very dynamic. But yes, all of our intensive care units are very, very busy.
Just one more follow-up question. Is it ever going to, or at what point would we stop being able to take in patients from out of state? Would that ever interfere with Idahoans and being able to treat them in state, I guess?
Well, when we are in the business of healthcare, all of us, anyone that I know who's in healthcare, it is really our calling when asked to help and to take care of patients. So if we get called, we are going to do everything we can to take care of that patient. That being said, just to help you understand how serious the situation is that we are in the process of opening that additional intensive care unit. So this is something that is not an intensive care unit. It didn't exist as an intensive care unit, wasn't built to be an intensive care unit. So we are pivoting to that. And remember, it's not just room and physical space. We now have to find extra intensive care doctors, extra respiratory therapists, and extra critical care nurses to fill a unit that we never even had before as a critical care unit. So those are the kinds of things that are going on every day in our community and across the country. And yes, there could be a time where we just don't have the ability, whether it's through, it probably won't be a space issue. It's probably going to be a resource issue. There are only so many intensive care doctors, for example, and the best care we know for critical care patients is coming from people who are experts in taking care of those kinds of patients.
And one last question, sorry. What percentage with the Delta variant circulating, we're hearing that the percentage of patients having to be intubated is higher than it was before. Is that true?
I have heard that anecdotally, but I cannot confirm that. What I can confirm is, again, we are seeing as high or higher critical care need than we ever have, including our pre-Delta virus surge last winter. I also can confirm that on average, our patient age is significantly lower than it was at the prior surge. And the reason for that is crystal clear. It is because the people that were getting the sickest early on the older patient population and people who are living in long-term facilities, the majority of them are vaccinated and so have at least some protection from the Delta variant, whereas the majority of young people do not have any protection from the virus right now.
Thank you very much.
Thank you, Dr. McGeorge. Rebecca Boone, can you please unmute and ask your question?
Hi, Rebecca Boone from the Associated Press. Some of the criteria for immunocompromised people seems somewhat confusing. It says people on immunocompromising drugs, but doesn't necessarily list them all. How will people know if they qualify or if they're on a high enough level or dose of a drug to be immunocompromised? And will St. Luke's be specifically reaching out to patients under its care who might need this third dose?
Right. So the answer is, so two questions, great questions. The CDC, you're right, and the FDA, they do list conditions and they are more vague on the actual drugs and the doses. And this is why it really is best practice. It's not required, but best practice to talk to your doctor. And again, the rationale is that, for example, if you get a medicine that is an infusion, it may be that you want to get the vaccine, that booster, or that third dose of the vaccine 2 to 4 weeks before your next IV infusion, so that your body has like lower levels of the immune compromising drug or immune suppressing drug in your body. So at the time that you get the vaccine, so you can at least benefit the most possible for you for that vaccine. There could be other reasons, visiting grandchildren, might be a reason that the timing of it might want to be timed well. And so again, that is really the reason that I would encourage people to speak to their provider, whether it's their rheumatologist or their primary care physician or their oncologist, whoever it is that is most familiar with their immunocompromised position. That's who they should speak with. So the second question is, will St. Luke's be reaching out? And the answer is we don't currently have plans to do that. And the reason we don't have plans to do that is for the exact reason that I was just explaining, is there really is a lot of individual, there are individual aspects of it that need to be taken into account for each patient. So we want to be there and be available to vaccinate people, but we really do want the patients to reach out to their providers.
Thank you.
Thank you. Katie, can you please unmute and ask your question?
Good morning, this is Katie Terhune over at KTVB. I had a question about the Delta variant specifically. We've previously been told and heard from the CDC that there's less risk in an outdoor setting, but especially in light of St. Luke's canceling the outdoor Fit1 race this year or moving it to a virtual race, does the Delta variant spread more easily in the outdoor setting? And should the public be concerned about some of the big outdoors events coming up, like the Western Idaho Fair or Treefort next month?
Yes. So yes, people should be concerned about outdoor events. So, there was a nice graphic that was put out by the CDC on the prior, so non-Delta, the other variants. Essentially, roughly anyone who has that virus, potentially spreading it to about 2 people, and then those 2 people spread it to 2 people. So now you have 4 people, and then those 4 to 2, and now you have 8, and so on. With the Delta variant, you could put a number 6 in there instead for typical, how many people one patient spreads it to. So now if that one patient spreads it to 6, those 6 spread it to 6, you quickly now have 36 people, each of them spreading it to 6. So I don't know that it's any more infectious outdoors per se. I think what you would say is it is just significantly more infectious, period, end of sentence, significantly more infectious. I again am extremely concerned about what I'm seeing in the community, both indoor and outdoor. I try very hard to support my local businesses, and actually 2 nights in a row, probably because I work too much or something, but 2 nights in a row got takeout at restaurants and really was practically the only person there that was vaccinated, and business is booming and people are in very close contact with each other, you know, very close to each other for long periods of time in restaurants, and it is really spreading. I have no doubt that these situations are spreading the virus. As far as an outdoor setting, yes, this can spread in the outdoors. Great example of a way that this would spread in the outdoors is if you think of an outdoor social event or cocktail party where people, again, it's the being outdoors without a mask and being in close contact. So if you can smell someone's breath, or if someone sneezes or coughs or anything, you know, in that region of you, you pretty much are breathing their air. And yes, you know, if you're in an area and you're further apart, like 3 or 4 feet, 5 feet, 6 feet, even better, and it's outdoors, those airborne viruses can quickly kind of spread out and go through the environment, and so are lower risk. So I would say, you know, and the reason we canceled Fit One, they're not canceled it, but aren't having the in-person event, is we know people are just huddled together. Even some may have masks on, some might not, but you know, you're just within a foot of someone else's face talking to them, and yes, you can spread virus that way.
Thank you. And then one follow-up question, if I could. I've heard on a national scale that there is at least talk of at some point everybody getting a 3rd booster, or this becoming like a yearly booster, like a flu shot. Is that something St. Luke's is looking at? And would there be a timeline for, I guess, just regular people who aren't immunocompromised to get a booster if they want one, or to be asked to get a booster?
Well, again, we're looking to see, you know, to get further information from the FDA, and expect to hear that in probably within 2 or 3 weeks as the data is reviewed. But we are, as you heard, you know, are expecting that for healthcare workers and long-term care facility residents, that we would expect to get a 3rd dose of the messenger RNA vaccines. I know for those who got Janssen or the Johnson & Johnson vaccine, they're not at the 8-month period anyway, but that too is being looked at, and we're expecting information on that. So I want to clarify this dose that is coming to me, for example, 8 months after I got my 1st and 2nd vaccine. That is the same vaccine, only a 3rd time from earlier this year. So it'd be a 3rd really in the series for the vaccine. I anticipate and hope that yes, we will have other vaccines coming down the pike in the future. Just like if you think about influenza, that if you've had influenza or had influenza vaccines, you may have some protection against influenza, but we really want to match closest to the variants that are circulating, sort of along those lines, having, you know, as the virus continues to mutate, I would not at all be surprised if there are different annual vaccines or, you know, periodic vaccines for COVID, and really, people probably need to think about this more along the lines of how we think about influenza, that we do just expect to get a periodic vaccine to be protected. So I would compare it that way to influenza. It's not at all comparable to influenza in that it is more contagious and much more serious a virus. Obviously, I mean, we've never had intensive care units overwhelmed with influenza.
Thank you.
Okay, thank you. I see, Katya, you have another question, and then I also have one in the chat from Karen Bosick after that.
Yeah, back to the ICU situation. Where can patients be diverted to if they need to be? And have we come to the point where you've had to turn patients away?
Well, so we have had situations where we have been on divert, yes. I don't have the details here, so I can't speak to this, but I do know that the state is working with the hospitals across the state to try to be up to date and be able to make that process, excuse me, make that process as seamless as possible, so that physicians in the emergency room, when they have a patient, they're not having to pick up the phone and call 10 different hospitals to try to find a bed. So I know there is work being done to that regard, but if a patient comes to our ER, we are going to take care of that patient. And if we don't have a bed, we will work to find them a bed. And by the way, sorry, one other thing on that. I think we continue to think about these COVID patients. And just like we saw earlier in the surge with the pandemic, I want people to really think about is heart attacks and stroke continue to happen. And so we want, if someone thinks they're having a heart attack or thinks they're having a stroke, also known as a brain attack, we want them to call 911 and get seen. But what I also want people to understand is all of these COVID patients that are taking up these critical care beds are also, we need to be able to get those heart attack patients into those beds and those stroke patients in too. So it is not just COVID patients. Our volumes for those other diseases are, about where we would expect them to be, but it is, it's this additional massive volume of COVID hospitalizations that are really putting a strain on the system.
And just for clarity, earlier you kind of compared your current status in ICUs with where we were last winter, and you were saying the situation is more dire now, correct, than it was?
Yes. Mm-hmm.
Wow.
Okay.
And sorry, just to follow up on that, what is really striking to me is that situation, seeing that, knowing that, hearing what is going on at St. Luke's, all the work to try to respond to this, and then walking out and seeing things going on that are as if there were no pandemic, and whether that's concerts, large gatherings, people not masking, those kinds of situations just make me, I am completely confident that this is going to get worse before it gets better, because based on seeing what we're seeing with community spread and what is going on right now in our communities.
It's truly sobering, Dr. McGeorge. Karen Bossack from Ion Sun Valley writes a question in the chat. Should people be getting their flu shots earlier this year, given the fact that respiratory diseases do not seem to be following prescribed schedule this year?
Yeah, that's a great question. Last year we hardly saw any influenza and hardly saw any RSV. We are starting to see some RSV this summer, so that of course is concerning. So the wild card is the reason we didn't see influenza last year. We were all very, very nervous about a double whammy of getting influenza patients and COVID patients filling up our hospitals, but even worse, having some patients who are infected with both, and then of course having a higher risk of being very, very ill from that. We did not see that much influenza last year, and it is because of the masking and the physical distancing. So a couple of things is, yes, get your flu shot. If you happen to be in a group where you should be getting another COVID vaccine, you can get your flu shot and the COVID vaccine at the same time, as long as the facility has those and will be ready to do that. At St. Luke's, we won't be having our flu vaccines available probably again for another month. But, just for an efficiency reason, it is helpful to get both if you happen to have those available. The ideal time for the flu shot is still not, it's a little early for it, ideally September, October. But again, masking is going to be really important here.
Thank you, Dr. McGeorge. I know we're at 11:30, actually a minute over. Do you have time to take another question or two, or? Great, okay. Hayat, I know that you have your hand up. Can you please ask your question?
Thank you. I was just wondering, are there any hard lessons healthcare systems learned from the last time they needed to cut down what services they could offer? Obviously, St. Luke's has cut down on some elective surgeries. What can healthcare providers do, if anything, to avoid a bottleneck of healthcare needs once COVID slows down again?
Well, I think what is important, I think one is I would emphasize to the community to use the emergency room if you have an emergency, a life-threatening or limb-threatening emergency. If you do not, please use urgent care or your primary care office to try to decompress our emergency rooms. Gosh, as far as what we could you rephrase that question again or restate the question?
Yeah, what were there any hard lessons that hospitals learned from the last time there was a COVID surge and you had to cut down on certain services, healthcare services? And is there anything you do differently this time around to avoid a bottleneck?
I don't know what can, certainly having our staff trained and ready to go and well. So I would say one thing we're doing differently is requiring the vaccination of our employees, because don't forget, our employees live in the community and they get sick from COVID. And so that is one thing that can help us staff, is making sure that our employees are vaccinated. You can't staff up for a pandemic every day all year. And so I think, just being able to, again, go through the list, what is life-threatening today that we have to do? I mean, we are essentially triaging in the sense that we are saying, okay, this person has an elective surgery. Would he or she like to get his or her knee replacement next week? Absolutely. But is it more important that we're able to take care of this COVID patient who, if we don't, could die? Then yes, we have to make those decisions and take care of the patients that need us right now. So I think, again, redeploying our staff where we can and how we can, but we will, again, always take care of the sickest and most immediately urgent needs first, regardless, of whether that need is a stroke or someone who's really sick from COVID.
Thank you, Dr. McGeorge. Troy from Boise State Public Radio wrote in the chat, what is the average length of time COVID patients are staying in the ICU and how that compares to non-COVID ICU patients?
So anecdotally, the length of stay is longer, but as far as the details on that, we would have to get back to you.
Great, we will do so. We'll follow up with you, Troy. Also, Karen did write in the chat, if we did not have Delta, would we be seeing the need for boosters as soon as we are? I'm wondering if vaccines are 90% effective against all other COVID variations, but maybe only 50% or so around Delta.
Well, I'm going to say, I would like to say that's a moot point right now. Because we have Delta and it's somewhere between 80 and 90% of the COVID that we have in the US. So it doesn't matter anymore whether we would have from the prior ones. I think that it's hard to know because the Delta, when we're looking now, we're looking at cases where we're seeing Delta. So when they're studying effectiveness of vaccine, they're studying it against the real world, and the real world is we are inundated with the Delta variant. So it's hard to weigh that against, well, gosh, if we imagined we didn't have the Delta variant, would we see waning antibodies? we'll never know the answer to that, because the fact is most of what we have now is Delta. And by the way, fast forward 6 more months, we can expect more variants. So that's why I think people need to just think about and be okay with that. This is probably going to be the type of virus that over time we periodically need a booster or, another dose of the vaccine.
Thank you. And then Katie, we'll make yours the last question. Please go ahead.
Oh, I apologize. I hit the hand raise button on accident.
Okay, thank you very much. Dr. McGeorge, do you have any closing remarks?
No, I just be safe, everybody. Please take care and please be safe. Thank you.
We really appreciate you taking so much of time today out of your very busy schedule. Thank you.
Okay, thanks so much, and bye-bye.